Dr. Mganga. And this will take me to the next question, just coming to you as well. So, the National Action Plan provides a roadmap on antimicrobial resistance implementation at the subnational level, correct? So what capacity building initiatives are most critical for regional and district health management teams to effectively track antimicrobial resistance data? Maybe you can highlight us on this issue.
Thank you very much for the very good question. The biggest role of PMORAG is, should I say it first before answering the question, is to receive and translate the directives from the sectoral ministry and send it to the regional secretariat and local government for implementation. So if you have listened very well the presentation of Professor Matei, he mentioned the drivers for MR. So to my thinking, the initiatives that should be in place to strengthen the MR should be reflected to the drivers, the professor has said. One is we are missing the surveillance data. So should there be an initiative to strengthening how could the MR data, surveillance data being captured to where the implementation is being done, mostly in the local government authority. Two, if I remember, he mentioned the diagnostic, the laboratory. Should there be an accreditation of the district and regional laboratory to enhance the diagnostic? Another one is One Health. Yes, from the guest of honor, he mentioned the presence of a national multi-sectoral committee that in every 3 months they are sitting to discuss this MR agenda. But unfortunately, we do not have a multi-sectoral committee at the regional and council level. So should the Dr. Upendo project see how to support the presence and the existence of the sectoral committee at regional and council so that that could be an agenda. The last one is just an advice. Yes, we may be in need of this surveillance data and all other informations. Are these indicators related to AMR being integrated to the health system that the facilities are reporting on daily basis? For example, at LGAs, we have what we call DHIS2, the system that reports each and everything that is happening at facility level. So yes, probably we may have a surveillance system. I don't know it, but I think what is most important is to have or to stipulate the indicators related to what you want and being integrated in DHIS2 so that the facilities, the community, whatever level would have reported it, and the multi-sectoral committee would have observed it. So that is one. Two, yes, Upendo has said about the financing mechanism that currently it is donor dependent. Even the professor said. It is not that the government does not want to fund on AMR, but for the government to fund, everything should be highlighted in what we call CCHP, Council Comprehensive Health Plan. There are 12 priorities that the sectoral ministry has highlighted, that these are the priority for the country. Now, if we think AMR is a priority. That is very fine. And it is. Right? Now, should we take these research evidence data we get here and the contributions that everyone would have contributed and ask for the sectoral ministry to incorporate in the CCHP guideline that the plan will not be passed if we don't see the MR agenda. And if we succeeded, there is where the government will fund all what we want, strengthening laboratory services, probably having a sectoral committee at region and council, anything or any activity related to MR. If it is within the CCHP guideline, then we will succeed. Thank you.
Thank you very much. And if you can pass it over the microphone. Yes? Yes, Prof. Karibu.
It's about the National Action Plan on Antimicrobial Resistance, isn't it? The 6 objectives. I think the government has been participating in the making of these national action plans. The issue is how, and the plan is costed. It is a 5-year costed plan with a budget. Now the issue here is that we may be discussing the whole day, how much of this cost does the government commit? If there's no commitment in terms of finance, it will be small projects like Upendo's, and once the project is gone, there's no scalability or sustainability. So my question to the gentleman who was the last speaker, I mean, do you know how much does the plan, National Action Plan 2023-28 cost? And what is the relative contribution of the government to that? Thank you. Relative to donors.
Thank you, Professor Mate, for the question.
Should I respond? So, Professor, having a national action plan is one thing. Incorporating those 6 areas under the national action plan in the district council plans, in the regional plans, in the health facility plan is another thing. Have we incorporated them within these plans? Because in government, on every annual, the facility, the district, the regional, the national, we are creating our budget, our plans. Now those plans are the one that brings funds through the government. Yes, we may have the national action plan, we have multi-sectoral, whatever committee we call it. Are they in the plans? So my advice was, could we request, please go and read what we call CCHP guideline. You'll understand what I mean. If you understand the CCHP guideline, you'll understand my agenda. This is the health sector document that requests funds to the governments on an annual basis after parliamentary approval. Thank you.
Okay. So I see that you could not pick a number, but if any of the members, but you've actually directed us where we can go. And you've even given us an action item that to come out of the commendation of this workshop is to make a clear point that AMR is a real issue that will cost the country. I know, Professor, you've presented it, but is it reaching the policymakers? Are they able to prioritize it as a key issue that need to be prioritized for budgeting? And
should I add another thing? We have, I think even here in MOAS, you have what we call PEPMIS. Yes?
Yes, we do.
So if the MR could be requested to the sectoral ministry that whoever is responsible for MR in his or her PEPMIS should be part and parcel of the reporting, the implementation of it, right?
Yeah.
That could reinforce, because these members are the ones that set in the budgeting plan. If this is my core business, my activity, then why shouldn't I send it to the plan so that it can get fund for me to oversee it during its implementation?
Okay, we get your point, and if any of the panelists has a quick point on that, we also, because it seems to be a burning question, I think it came out in all the discussions. So panelists, please feel free. You can, on the same point, so that it's clear. Dr. Kayuni. Okay, let's
thank you. Just to
finish and then.
Just to highlight a few things. I think the issue of funding is really challenging, but probably one of the things that we can start, for example, I don't want to go to region and district, that one Dr. Matthew has highlighted, but at least at institution level, if we could start slowly integrating, you know, like budget line for AMR in our respective institutions, I think that one should be able to support. Through Fleming, I think when Fleming country grant was coming to an end like last year, I think one of the things that we were really pushing forward was, are we now ready to sustain whatever we have invested in you? And a few hospitals have actually started integrating their hospital budget. They're actually putting like a budget line for AMR. I'm from Bugando. So for example, in Bugando, when you go there, we have a budget line for IPC and AMR within the framework of quality improvement. A couple of million, not really a lot, but maybe 100 million or so in a year. And we are sure that budget line can actually help the institution, at least to fulfill some of these obligations. So if we could probably start with that, and then now we keep on building a case now, that will probably cascade now from like hospital, then maybe to district, maybe to region, maybe. But at least we need to have somewhere where we can actually start.
Thank you very much, Professor. So, you know, Dr. Sharon has done some quarterly assessment at their hospital. Maybe you want to contribute how they are funded, and then we see if, just quickly, because your question is coming, Doctor.
So for Muhimbili National Hospital, we have been doing the quarterly PPS survey, and all has been funded by the Fleming Fund and MUHAS and some from the Ministry of Health. So we also get support from the Fleming Fund.
Okay, thank you for that. So indeed, you should look at how you're going to sustain this kind of seasonal funding. Dr. Kayuni, and then we continue with the next question.
Yeah, thank you. I wanted just to make an elaboration. Or if you see who is asking this and that one, people, they have to know what is MR, first of all, and how the National Action Plan have written about that. What is the gap, how they have addressed on the National Action Plan. And also, what is the relation of normal life, daily activities to AMR? Because some they are doing AMR activity and then they don't know that they are doing AMR activity. It's like, I want maybe researcher to research to see the government budget and the MR activities which are within the government budget but does not written MR. It's like national. It's like Ministry of Health. They are budgeting millions of money on control of drug control, which they are putting aside. That one are MR activities, but does not written MR activity. It's like in Ministry of Livestock, we have some of the projects, like the project of vaccination. This is the MR activity, but they are not written MR activity. So if we want to go to maybe to see what is the MR activity and how they are costed in the budget, you will see maybe you couldn't say the raw percentage. Maybe you could say 50%, because all the IPC also if you go to national laboratory, they have budget for the laboratory activities. These laboratory activities, which is concerned for surveillance and the genomic also, especially, which they have started, which these ones are MR activities. So I think we have to say by viewing from that standpoint.
Okay, so thank you so much. I think Professor Mate is still digesting. But I think the way government works, it's like you really have to show what you want to do in the different documentation. So we have, for example, the 2050 vision. I'm not sure, Professor, you are included in commenting towards making that. And then we have the strategic plans for every ministry, I think, and organizations. And if we are not part, and you can maybe, given this opportunity, explain to us how well this is working.
Thank you very much. Data sharing in One Health approach is very common problem. It's known from, it's a time now. We speak about the data sharing platform. But for now, Prime Minister's Office designed disaster management information system, which include One Health platform for data sharing. We have been a number of several meetings on discussing what data should be shared from ministries, agents, even universities, MUHAS, and so on, regarding to the data obtained from the research. So we have that data sharing platform. It is in final stage now. We have the data agreement forms or letters go to Ministry of Health and the Ministry of Livestock as the starting point, because those are ministries which have the data system so that we can share or integrate that data. And the platform is already there. And those developers who already work on the dashboard, waiting for that agreement so that we can have that platform very soon. Thank you.
Thank you very much. So it seems there is quite work going on this, but if anyone wants to give any additional contribution to that, are we happy? Are we really involved in the development of these tools? Or are we going to be involved after results have come out? Stakeholders.
I think that's where we're missing the important issues, because if there's something to be formed that needs to address problems of the community, I think the stakeholders need to be involved, and not only academic and research institutions, but also community engagement.
Yeah.
Stakeholders have, because what is going to happen is that the tool that is going to be developed will be like a white elephant.
Maybe it's a bit too early to say that, but I think the tool will be there. This is that's also my thinking, that is a very high level tool that will be developed. So the question is what you brought, Professor, whether all the stakeholders are involved, not only the academics like Professor Mate, but also the community. So my call is for the community. This should not just be the very, very high level where the minister is looking at the dashboard and seeing what is happening in the environment sector, what is happening in animal. It's all about how it trickles down to the lower levels.
Okay, thank you. To start with, we start with those ministries at national level, and later we can see how it goes to the regional or district. But to start with the national, because let's see, Ministry of Health, they have DHIS2, they have AFIA, whatever. Are those obtain the data from the roots, from the community? So we see we are not very possible for Prime Minister's Office to ask the data from the community rather than to ask the ministry concerned. Even to the livestock and fisheries, the same, Ministry of Agriculture and others stakeholders. Thank you.
Yeah. So thank you. Glad that you have also considered that. I will come back to you if we have time. But the next questions will go to Dr. Joseph Malakalinga. And in this case, we will take a look at the food chain. And the question is, with the recent focus on foodborne antimicrobial resistance, what are the limitations of the current food safety regulatory framework in systematically monitoring the issues of antimicrobial residues and resistant bacteria in meat and dairy supply chains? Professor indicated how he worked with his students, and they have observed across several food chain products, noting widespread residues presence. Please enlighten
Thank you
us.
very much. Yes, I have to acknowledge that there has been a delay in implementation of AMR surveillance in food chain. And this could be the reason due to the most of the guidelines that govern the food safety, they are not addressing the antimicrobial resistance. So most of them, they aimed at safeguarding the public health, just by saying that food maybe should be free from contamination, especially for like Salmonella, E. coli. So this, I think, was a limitation how the institution could implement the AMR surveillance. But recently, we thanks the National Action Plan, the old one was not addressing the issue on antimicrobial resistance in the food chain and issues on environmental antimicrobial resistance. But the recent one, the new clearly addresses the AMR in the food chain and pinpoint the responsible institution. So on our side, the TBS, based on in reference to this National Action Plan, we were now able to communicate with the management system that yes, we are pioneering in food safety. So we have been doing good, but we lag behind on the antimicrobial resistance. And we showed some evidence on some parts of the National Action Plan. So from there now, I think it's an approach now for other institutions to rely on National Action Plans, as we have used on our side at the TBS. And from there, we managed to convince the management. And we included the AMR surveillance issues on food safety in the budget. And currently speaking, our laboratory has a capacity now. We are doing antimicrobial stability tests using disk diffusion method. But now we are doing MIC using the VITEC, the modern technology VITEC machine. So, and now we have also established the AMR surveillance and gene resistance genes to foodborne pathogens that we isolate from the food sample. So, what I would advise to other institutions, although there are some guidelines that have not mentioned the AMR, as one of the speakers was saying, that did you, okay, the national plan is there, but did you put it in a track so that they can put in the budget, the respective institution? So I think we should take effort first to rely on the National Action Plan, but we can also review our guidelines, the previous guidelines, to include the AMR. As we know, One Health approach has been a new discipline in Tanzania. So having said that, TBS now, we are extending our capacity to genomic level, and there was a discussion with the management on how, because we have a section for food safety. So that section needs to track also the infection. And you have seen the genomic surveillance as one of the tools for tracking the infection. But that was on diagnostics. So the capacity nowadays, we have the capacity. Okay, I will encourage also and most of the data, as you see, we have been depending on the students' research. But the national surveillance data, we are not there. So currently, we have more than 300 data, and we've been sharing to National Technical Working Group. I'm a member of the Technical Working Group on surveillance, but also to MCCM. There are some members can acknowledge the contribution of the TBS. So the data contribute to the policy making and as guidelines for in food safety. But to extend, not only on diagnostic services, we think of integrating the AMR issues, because to rural areas, I think that to respond to the next question, we include the AMR to the rural areas. How do you approach? What was the challenge? Yeah?
And you do some sampling. Perhaps they will be interested as consumers of the food industry, where you do this sampling, what triggers the sampling actions, how much budget, you already acknowledge that your institution budget is, make a budget on these issues. So perhaps you can tell us, where do you sample? You know, the food security, we have travelers coming from abroad, and they encounter all the food issues that we have. So do you go to hotels? Do you wait when there is an outbreak and get the samples, and how much budget goes into this?
Okay, let me respond. At TBS, we have two kinds of surveillance, the passive and the active one. So the passive one depends on the routine sample submitted for conformity assessment, checking the quality, whether they comply with the standards, established standards. But the other sample based on this we call typing test. A client come and they want to understand, to know the status of a sample, not for the market, but like water samples. So they bring for knowing the status. So those kind of samples we'll see. But for the active surveillance, we target the wholesalers. Like now, in the February this year, we had the active surveillance on AMR in meat. The study conducted in Dodoma and Dar es Salaam, Dodoma, Dar es Salaam, the coastal region. So we were targeting at the market level, street vendor, and the butcher area. But we have seen some, we need to extend our scope to like transporting logistic issues, like transporting of food materials, food products. So for now, we have a plan to, we depend, we based on the National Action Plan, but the Codex Alimentarius. And also we have, within the TBS, we have developed a standard for AMR surveillance along the food chain. So we have highlighted a lot of factors over there for AMR surveillance. So including retail, producers, food processing areas, yeah, and even in the market. We have some market surveillance.
Okay. So yeah, thank you. So I will come back to you. So it seems you are doing at, again, a high level. And the next question will be how you go into the community when we come back. But Professor Mate has... Yeah.
And the student work which we projected here is based on the cheap budget, 1 or 2 antibiotics. Hello? Can you hear me? Yes. The research that students did here is very useful, but is limited in scope. I would like to assume that there are much more things in the food that we consume, including pesticides and heavy metals. Yeah? So I would like to advise the Ministry or TBS that it is no longer an issue now to find out whether there are residues in food. That is already established. What I would like to hear is the mechanism which you are going to employ to protect consumers from these unwanted, some of them carcinogenic substances. Thank you.
Yeah. Yes, thank you so for putting that one clearly. And there's another question, and you respond to both. So, okay, normally we should hear the presenters and then have the question and answers, but I'm making an exception, maybe only one time.
Thank you. Thank you, Chair. Actually, I wanted to add on what you asked.
Yes, Doctor.
Regarding what Dr. Joseph was saying, and the Professor just mentioned it about how do we safeguard the consumers. But again, I want to also bring on board the issue on how do we also guarantee the producers. Suppose you the level is too high and I'm already in the market and I'm selling to feed my children. What will happen again? So I wanted to add on that. If he can respond, or anybody in the board. Thank you.
Just adding up to that, if your children didn't die, maybe, yeah, let's see what he's going to say. Can you let us, the panelists, answer to those questions, and then we'll come back to you. Just keep the questions. We'll come back. So this apparently is a very interesting topic, as you can see. The audience is very excited. So there is a question of the consumer. There is also the question of producer, but that is another industry, the agro and veterinary industry. Can you just put some extra information to that?
Yes, to respond to questions, I think I can combine all of them, the issues of residues and pesticides. So first, there are standards that govern the quality of the food. And these standards are being created based on the risks of residues and pesticides. So most of the oral products that are supposed to go to the market, they are tested. So if they comply, okay, they are released to the market and can be consumed. So because we are sure that by doing so, we are protecting our consumers. But for non-complying food products, like residual limits, because you just reminded me, we monitor also residuals, pesticides, residuals, also the antibiotics residuals. So non-complying food products are not allowed to the market, are destroyed, and we restrict them. We can be destroyed by during recalling. There is issue for recalling, also the issue of destroying the food product that has higher limit of the amount. So doing so, we've been protecting the consumers. But manufacturing, we have programs at the TBS for training the small manufacturing enterprises, including the bigger ones, and on GP, good manufacturing practice, to avoid the contamination of foodborne pathogens, including the acid.
So I don't know if your question was answered, but what I'm picking over and over is that there's a regulatory framework. They do take analyze, they make analysis. I think what Professor Matei wants to see, and I think for me, this is a call that we meet together, because probably that information is never published. It's only used when, for example, there's non-compliance. They will go and they make a stop order. So it's high time that the information is published. So Professor Matei, maybe we can sit, I think, in the sectoral committee and start looking at that in detail on how that information can be shared. And I hope this can be one of the recommendations from this dissemination, that we sit together and work out what are the cross-cutting. Because when the patient comes, they will go to Professor Seni. It's no longer to our hand, so it's now flowing to Dr. Sharon, Professor Seni. They will have to handle those patients. It's already out of their control. I'm not sure if someone will ask on the consumer advocate group. Yes.
I think if I've understood Professor Matei, what is needed, what is the mitigation?
Yes, so the
mitigation.
The data is collected.
So should, if on top of what doctor has explained, should it be sent to the National Multi-Sectoral Committee so that we can get a resolution there? Because there are more than what he explained. The mitigation need to be done. More than that, yes.
Yeah, thank you for adding that, Doctor. Yes.
And I think it would be very nice if these deliberations are shared with stakeholders who are, most of them who are here. Isn't it? As a catalyst towards making the necessary changes.
Dr. Upendo is recording all the discussions that are going through with our team.
Good.
Yes, Dr. Kayune.
Yes, I wanted to say that this one is not maybe the final meeting. Just we are estimating some of the gaps.
Yeah.
And I think those who are contributing, it's better if you contribute, instead of asking what are the conclusion, you just say, maybe I suggest this one so that the idea could be taken to where the platform, the decision-making platform.
Okay.
This one will help this meeting.
Okay. Thank you. Thank you very much, Dr. Kayuni, for that. Okay, for the sake of time, let us continue. We'll come back for a few additional round of question and answers. But now let's move on to Dr. Sharon. And this time, we are going to look at the health facility level AMR and stewardship activities that are going on there. So given that the clinicians are critical to antimicrobial stewardship implementation, and the majority have not received some form of training in this particular issue, how can we embed stewardship mentorship programs into the daily hospital routines? Karibu.
Thank you, Professor Sangeda. I am glad to be here and share experience on the clinical grounds as we have been discussing and we have been taught in microbiology about the resistance pattern and how the patient will present, but now in the clinical grounds, things are different. We have seen from our key speaker, Professor Mate, that we have 47% of the referred patients, they are on antibiotics. So that was 2020. Maybe now we are discussing a higher number than that. So the way that I think we can embed the mentorship into the clinical grounds, I think now we can come out of the classes and have a point of care learning. So instead of sitting in a class and teaching people about AMS, AMR for 2 hours, 3 hours, maybe we can take them into the ground and have a bedside teaching on a case-to-case basis. We have improved. As of currently, we are having a multidisciplinary ward round. In infectious unit, we have a ward round discussing an infectious patient with a clinical microbiologist. We have a clinical pharmacist. So all those are acting as mentors. Whenever they see there is a sample, maybe it's not yet out, a clinical microbiologist always helps us to get the results and even to interpret the results. Because sometimes you can find a clinician is not able to provide the right antibiotic because a microbiologist have given like 4 drugs, which are all sensitive to the same patient. Now a clinician will stuck, which one should I choose? So maybe now we have to go into an era of providing a cascading report. Give us one antibiotic which is available in our setting so that we can use it. And that should be affordable to a patient. Another thing that as IMS in a healthcare facilities is to have the AMS champions. So in Muhimbili, we have a group of 20 AMS members, and these members have been institutionalized with 3 years terms of reference. They've been selected from different departments. So whenever we train these few members, they can be as champions in their own departments in mentoring the junior staffs. Coming into the formal training, I agree, clinicians are the main part of the AMS implementations, are the one who prescribe the medications. But every year we receive a group of interns cut across different cadres. We have intern doctors, intern pharmacists, intern lab scientists, we have intern microbiologists. All these can be trained into AMS during their induction program. So at Muhimbili, we have a 2-week induction program for every new batch of interns, and we can use it to cement this knowledge about the AMS. Another thing in a healthcare facility is to link the IPC and AMS programs. So I think by doing this, we can embed. But there is something about doctors, some are resistant. So we need something that we can enforce. It should be a must that whenever you prescribe a medication, you should review your patient, maybe after 72 hours. See if there is any improvement. So by saying that, we can have a way of having a prescription timeout. Whenever we prescribe anything after 72 hours, maybe an automated system can tell you, no, you can no longer prescribe this drug until you review a patient and have maybe discontinue the medication or treat a patient into a narrow spectrum antibiotic. So I think those are the way when we enforce them into our junior staffs, they can help to reduce the AMR.
Very impressive implementation at MNH. No wonder you are the pillar of the nation. But I see all the time when you are presenting, Professor there is shaking his head. Perhaps he will add up something on what you have just said. Professor Sen, please. On this issue of clinicians and how the practice goes in the clinic.
I think what you has said is really important. So at Bugando, I think we are more or less doing the same. We are not communicating, but I think we are doing the same. So we also have the joint major round. And because the team in the stewardship committee, we are fewer, so what we have decided, we have actually chosen the priority department in the unit, and we didn't just choose. We used our WHO PPs survey that we have been conducting for the past 2 years, and then we showed exactly where the antibiotics are used the most. For example, the proportion of use in the pediatric was like 90%. If you go to medicine, around 60. Surgery around 75%. You go to medicine, around 50. So we have specifically decided the 4 priority units where we do our major rounds. So number 1 is the pediatric department, and then number 2, patients who are in a critical care unit, so ICU, both medical and surgical ICU. And then because of surgery, so we have also decided we are doing also in the plastic and reconstructive surgery. So that's a unit, specifically the burn unit, because that's where we saw like the use was very high and the infection were also very high. So like we have now targeted the interventions on this. Pertaining to restrictions, I think that's something really good. I've said exactly like in the 4 interventions, 1 is restrictive AMS intervention, and probably should blend it in our online platform, so that at the end of the day we go. One key thing which clinicians are not happy with our committee, it is the turnaround time. So you take a sample, you get a result after 3 or 5 days. So they're not happy with that. So for us, what we have decided now, we are introducing a point-of-care molecular assay. So it's called a LAMP technology. We have already validated like 10 AMR markers. So you just take urine sample, you take blood sample, you put in a machine, within 2 hours, it will tell you it is safe resistance, carb resistance, or something resistance. So we are hoping as we wait for our culture, because we need that bacteria as well, at least we'll have something to guide. So we are piloting, and we're hoping if it will work, then we'll be able to scale up it in other countries.
Okay, that's quite impressive as well, having 10 AMR markers that you do a constant surveillance. I think it's a very novel and innovative that can be scaled. I like the idea of automation, the 72 hours automation, and getting reminders. But I'm a bit skeptical whether this will work in our setting, but I think it will be a very good idea.
So that's in idea, but currently when we are doing the AMS ward round with the microbiologist, we do it manually. It's just a reminder that we need to review this patient's antibiotic, but we are planning to have it in the automated way by informing the IT personnel in our hospital so that they can put it in place in our electronic health management system.
Excellent. So really good plans, and I think everybody is learning from this kind of experience sharing. So, yeah, thank you. I'm now going to move on, looking at prescription patterns in the animal sector. And so specifically I go to Dr. Emmanuel Mayenga. So as we saw in the human sector, in light with studies showing widespread of non-prescription dispensing in veterinary medicines, how can we improve the regulation and oversight of agro-veterinary shops in remote areas particularly? Maybe you can also look in the urban centers, but also in the remote centers. Karibu wote.
Yeah, thank you, Professor and the audience. First, I would like to point one thing, like in animal health sector is a bit different with human health sector. Like you cannot take an animal to the hospital from Bagamoyo to somewhere, but a human you can do that. So now, if you look on these differences, now you can even forecast how animal health operation is being conducted. As done, and because of that, now we find the importance of having a strong regulation to ensure that it regulates and it operates include to all the remote areas. One of the things the animal health practitioners, they are first registered by the Veterinary Council of Tanzania, and also including the animal health facilities like the agrovets and the animal health clinics. So if we strong, we are there on the legislation mandates and the law of this regulation and how to operate these agrovets, whether it is town or in the remote, we can find the outcomes from these agrovets. We have the treatment guideline that has been established by the ministry. So it is now time to cascade the use of these treatment guidelines at the local levels. So this could be a challenge, like my colleague mentioned. If you talk about the AMR at district levels or at the community level or at the ward levels, people will not understand because they don't practice. Or they practice in a different way, but is not popularly known or documented that you are practicing AMR. Like we have TMDA on the Ministry of Health, and then we have the DVS in the Ministry of Livestock, and then we have the BCT Council. So these, they are working together to ensure that all the drugs that are imported by the big distributors, they are all registered. And the drugs that are dispensed at the remote levels, those facilities need to be registered, including those professionals like the paravets that are working in that particular facility, in particular area, need to be registered. So, because these people are known, we can design like we can use the digital platform that we have now. You can have the AMS like a training, which is, you make it free. Everyone can access, do it online, and you make it mandatory for this person to get a CPD for his or her renewal of the license. That will promote the strong implementation of the regulations. And also we have the distributors, they are distributing the drugs from one point to another. So need to know that those facilities that are illegally operated don't supply any kind of drugs. This will help to reduce the misuse of the drug that's perhaps being sold in the remote areas. And many years back, you could find if you go to the open market like Mnada wa Ng'ombe, you could find antibiotics they are being sold openly. But currently the government has make a step ahead on that by having this the mobile agrovets with a car that have all the requirements for handling drugs. So now you may not find those people who are just like they are selling viatu, shoes, open like that. So, and now there is a law that is enforcing on some of the drugs that have been reserved like the way it is in human. Previously, those things were not there. If it is available in the market, for listing, you find it there. So these were the challenges. So those are the things that I can highlight by now. Thank you.
Okay, thank you very much, Doctor, for that. You've clearly given the highlight on what can be done. What I picked from you and from previous speakers, these big distributors, big farmers, in every meeting I've gone with issues of AMR, AMS, I've never seen these people come to these meetings. What I normally see, they probably come and they are big funders. Normally you see their names on the logos, but I'm not sure they are involved in this problem that we are having of antimicrobial resistance. Maybe their role is just to market their products, and they are not aware. They're just pushing the clinicians to prescribe their drugs. I would like to put this on agenda next time when we have a meeting like this, and maybe for them to be engaged as well in some of the national platforms or to discuss antimicrobial resistance. So I think we are running out of time. So I will ask the audience to give 3 burning questions for the sake of time so that we can continue to the closing session. There will be other platforms where we'll discuss these issues. And as a chair of the 14th MUHA Scientific Conference, I invite everyone who has posters outside or has not submitted, today is the deadline. That's another platform to discuss. Not as specialized as this, but yes, you are welcome to bring your discussions there. So now I open up, just introduce yourself. You can say who you are directing your question to, or make it general for any of the panelists. Karibuni. But before we do that, let us appreciate our panelists who has given us and shared their experiences widely. Let's give a hand of applause to them. Yeah, is that enough? Thank you very much. Thank you very much. So now, questions, ushers, you can take the microphones, 3 people, and then, oh, the keynote speaker also want to ask a question. Okay. I see 3 hands already.
Thank you. I am Elbarik Israeli, and my question for the person from TBS. Okay, we have seen in one abstract that there are a lot of residues of ARV in a lot of meat products we use daily. So, and most of them are human designated antiretroviral drugs. So as an organization dealing with standard, that is obviously a public health threat because it is causing drug resistance. So, and one of the recommendations there was banning the use of human designated ARVs in meat. So how are you going to implement that banning? And another question is, we have said that a big contributor for antimicrobial resistance is unnecessary prescription of antibiotics in our local pharmacies. So,
okay, only one question.
What are you going to do on that?
Question, you have one question for TBS colleague. Next. Thank you for that. Next, we have 4 hands. So we'll answer all the questions once they are done.
Good evening, and thank you so much, panelists, for very insightful and sharing your experiences around AMR-MS. I'm Harriet Nduma from the School of Public Health here at MUHAS, and small questions to Prof. Seni as the AMS Technical Working Group Chair for the MCC. So one is, so we see that it's around AMR stewardship. So we see that there are different, sort of prescribing behaviors across public and private sector. And I want to understand, how we can address the difference across the sectors, because we understand very well that, the prescription behaviors of the private sector is probably driven more by patient demand, financial incentives, as well as sort of perceived outcomes on better outcomes when patients are given strong antibiotics as compared to the broader spectrum and those that are lower generations. So are there, is there anything that is going on at that level to sort of address these differences across the private and the public sector, but also to, the penalties that you talked about, how are they executed? And last is, we understand very well that climate change is recognized.
Okay, I think we need only one question, please.
Okay, thank you, Prof. That's all.
Thank you. The last two hands.
Thank you.
After that, then Dr.
Good evening. I'm Zakaria. I'm directing my question to Professor Sen. He gave us a very interesting initiative that they have in Bugando regarding the AMR diagnostic markers that they're doing. I might just a very small question to Prof. Prof, do you have any evidence that you have seen so far with that initiative that you have seen that can contribute well in clinical decision making, especially in inappropriate or unnecessary use of the antibiotics to patients, perhaps improving the patient outcomes? That's just a very small question because it's an interesting thing that I have had in this room this evening. Thank you.
Thank you. Here, last question, Dr. Kibwana.
Good afternoon once again. I don't have to introduce myself. So my question is not for a specific person, but maybe perhaps to any government member, and if there's anyone from Farmers Council. So what is the take or the perception of the government on the use of non-lab testers to perform simple diagnostic tests such as MRDT, especially in peri-urban settings such as the ADOS, to reduce the use of antimicrobials? So what's your take on that?
Thank you. So now I'm not going to repeat the questions, so just let's give the microphone to, I think the first question was directed to our colleague from TBS, so we are going to give the microphone to him to answer that question about the ARV residues. Karibu.
Okay, thank you very much. Yes, there was issues on ARVs, and there was some publications that addressed the issue, detection of ARVs in some animals. But as far as we know, this is not a common, it's not a common treatment method maybe for using ARVs. In animals, we are detecting like antibiotic residues because it's widely used and it's used for treatment. So it's a kind of misconduct of farmers, maybe it's farmers. And I think this is at the farm level. I'm not sure if doctors, a veterinary doctor prescribe ARVs. So it's kind of misconduct that has been going on, maybe, I'm not sure. It has not been concluded to the beyond doubt. So anything for the compliance should have standards. And the standard is based on the risks assessment. So if there's issues like that, there's the option of developing standards. But for ARVs, because it's, I think the animal health now can help me there. For TBS, because we have a food risks section, we heard about that issues, and I think the data, we reviewed the publications, by the way, okay, and we seen there was some weakness behind it, so could not conclude that the RV are real the problem.
Yeah. So thank you, Doctor, for Dr.
But we have taken the concern.
Thank
we will present to responsible.
Thank you. Dr. Emmanuel Mayenga would want to comment.
Yeah. I think that was very, very interesting questions. One thing I want to point out is, I think there is no professional that prescribe ARVs to be used in pigs or in a broiler, or for our professionals. So we have to find out where is the source of these ARVs? Who is giving these people? If these people, they are known that, okay, this is the source of ARV, I think the Ministry of Health, they are the ones providing those ones. Whether they are given to patients and patients they decide to sell. Why are they selling? Is it because they are okay with the HIV? Or they are used to eat? Or they say, okay, whether I die, now I have lived for enough time, this is enough time for me to live, I should provide this to somebody so I can get money. But there must be something that is contributing to these people and sell the ARV to the farmers. So if we can control the source, and then these farmers will not be able to obtain these drugs like simply like the way you can get anything in the market. They are not sold in the market. There must be someone who is.
Thank you, Dr. Malakalinga.
Ethics is very important.
We have to spot the person who is able to supply the quantities sufficient enough to animals, because the animal dose is different from human dose. It has to be someone really on the, we need to identify that and actually actions be taken. Professor, you have been addressed a couple of times.
Yes, so I have two questions. I think the first one was on the public-private disparities. So, if you go to public, it's not like driving maybe the demand, right? And you're thinking maybe in the private, because also there is a financial incentive, so maybe you're thinking that one can drive. So if you look on our consumption data, antimicrobial consumption data from the national, there was a relatively higher AMC in the private sector, private hospitals, relatively compared to the public. But again, the consumption data is not like what is used by the patient. It is what has been actually procured by the hospital or by a pharmacy. So I think it's our high time now to go down to facility level. But if you go down to facility, if you look at the 2 rounds of WHO point prevalence survey that we did last year in June and last year in November, I think Aga Khan was also part of that. And if you look, it wasn't really, the use in Aga Khan Hospital wasn't really very far from the rest. So we are ranging from like 45% to around 65%. And even Aga Khan was also within that. One thing which was really appealing, when you look, if you compare data that Professor Mateo has presented, like what's the proportion of utilization of laboratory services among those patients who are given antibiotics. So the paper that we did across 6 regional referral hospitals and tertiary hospitals, it was actually, I think there were very few patients out of, less than 10 out of 500 plus. But when we did the repeat survey that we did, I think it has gone up to 25%. Around 25%. Hospitals like Muhimbili, Bugando, and the Aga Khan, they were all above 30. They were between 30 and 35%. So I think something is happening. We can't really blame like the private sector, but they are not probably doing whatever they're doing. If you look on the use at patients level, the proportion of use is more or less within the same percentages, both in the private and public. But then if you look on the consumption, like how much is procured, how much is it like brought in the country, and then directed to the private hospitals. So that was relatively higher in the private sector compared to public. So I think this is a wake-up call to keep on bridging the private public, whichever initiatives we are doing should not only be limited to public sectors, should go also to private sectors. And we are using Aga Khan because, Aga Khan has satellites almost all over the country. And we are thinking when you use Central Aga Khan here in Dar es Salaam, it will be easier for the stewardship activity to be cascaded down. So we're using Aga Khan as a model, and we are hoping to engage more and more hospitals. At the moment, I think it's Aga Khan, Hindu Bandal, and the Rabininsia, together with Bosch. So those are the 4 hospitals which are in the program. So I think we are looking forward to engage more and more. Then quickly, the joint, whatever we are doing, the initiative that we are doing at Bugando, whether they have brought a tangible outcome. I think I can give 2 examples. One, because now we are doing a joint measure round, we are able to timely detect the outbreak. So for example, carbapenem resistant sepsis or carbapenem resistant bugs which are involved in the skin and soft tissue. As I've said, from ICU and burn unit, we were actually able to contain at least 3 outbreaks, 2 in neonatal ICU, which were involving Pseudomonas, and Acinetobacter, which are resistant to carbapenem. So because of these linkages, so now there's an alert. If we get it in the lab, the lab quickly informs the IPC and the chairperson for the stewardship at the same time. And this one now works together to go to the unit, isolate that patient to like a designated room, and then we strengthen the IP. So I think that's something which we have achieved. Then the second one, because when we go jointly, we are also identifying which profession maybe have some gaps so that we bridge. So one of the things that we noted, we had high contamination rate, especially for the blood. Like for the past 3 years, it was around 15 to 20%, with a lot of coagulase negative staphylococcus. And when we quickly looked between the line, we realized it is actually the one who are doing phlebotomy. And mostly of these are interns, either intern doctors, intern nurses, or intern laboratory scientists. And you train this group, in the next 2 weeks, they are not there. You train again, after 2 months, they have been moved. So now we have actually integrated what my colleague here from Muhimbili said. We are also training, actually, stewardship and the AMR and the IPC training is actually part of the induction course for the intern. And when we started that, actually just last week, I had an induction course for approximately 25 interns from the nurses, pharmacy, laboratory, and doctors. So I think those are the 2 things, so reduction of contamination rate, when we identify that intern need to be strengthened in terms of knowledge, but also timely identification of outbreak and isolation of those patients appropriate so as to cut the transmission.
Thank you. Thank you so much, Professor, for the response. The last question, yes, Dr. Matthew, if you want to respond to Dr. Upendo's question.
2019, when I was heading the unit of health commodities and diagnostic services at the President's Office, Regional Administration and Local Government, I happened to be invited in a meeting by the Farmers Council. There are also representatives from Muhimbili. There was a push from these malaria people. They wanted to incorporate the test in the ADO and the farmers' premises. There was a very strong move. Now, by then, the Farmers Council, who is the one that register and oversee what should be executed within these outlets, rejected the request. Now, I'm not sure whether that stance is still in place or has been changed. Probably now we need to consult the Farmers Council, the registrar, that should these the ADO dispensers, the pharmacists, also hold their laboratory services within the premises. Thank you.
Thank you very much. Thank you. Very briefly, we have to close. Yeah.
Yeah, I wanted to add something from the animal health sector. like in the animal health sector at the lower levels, we have those rapid tests that can be conducted at farm levels. But the challenges has been how to carry this equipment or materials from the lab to the farms. So with the availability of mobile labs, I think we are going to have to solve this problem. TVLA will soon have the mobile labs that they can be able to move from one point to another. So I think the issues of diagnostics issues will be a bit reduced, and that will promote targeted treatment. Thank you.
Thank you so much, Dr. Mayenga. So this takes us to the end of this panel discussion. Once again, I want to thank the panelists for their time. They've traveled from very far to come here just to be with us. So we will give them a hand of applause, and we'll do that until they are seated back their seats, and while the MC comes in front. Thank you very much. Asanteni sana. Simameni.
So those who are for the panelists, now we want to put for the chair. The chair has done very well. We can put our hands together for him. Thank you, Professor Sangeda. And thank you for make sure that we are within the time. Now we have come almost to the end of this symposium. I would like now to welcome the Professor Doreen Mloka, who is going to give us closing remarks on behalf of the Deputy Vice Chancellor, Research and Consultants. Karibu sana, Professor Doreen.
Poleni, clap for yourselves. But I think it was very interesting. We had an interesting session. So not to take a lot of your time, let me just give I am not the DVC research. I am Doreen Mloka. I have been hijacked to this job. So don't think Bruno is tall and lean. I'm short and fat. So don't mix me up. So I think we've had a very interactive discussion, and we've opened venues for newer research. So to close this research symposium on AMR, I'd just like to give some closing remarks. And in honor of our guest of honor, who has already left, but representatives from the Ministry of Health, Prime Minister's Office, the Ministry of Livestock, who are all here, our French Embassy representative, who's already gone, deans and directors present, members of the National AMR MCC Committee, the chair, Professor Sangeda, for a wonderful job, members of the Department of Microbiology and Immunology, MUHAS, and I would especially mention Professor Matei, our keynote, and Dr. Upendo, our PMI for Rocket. And I would also like to thank all the distinguished panelists who are here, colleagues from MUHAS and MNH, MUHAS students, ladies and gentlemen, good afternoon. As I'm told, I stand before you this afternoon on behalf of the Deputy Vice Chancellor Research, MUHAS, Professor Bruno Sunguya, who is unable to be here with us today due to pressing engagements. So please indulge me for being him today. First and foremost, I'd like to congratulate the Department of Microbiology and Immunology, MUHAS, in collaboration with Directorate of Research and Publication and Innovation, for organizing not only a timely but an important symposium under the theme Advancing the Fight Against Antimicrobial Resistance in Tanzania, One Health Update, Progress Gaps, and the Road Ahead. This is so timely because the issue of AMR is a very pertinent issue. I think you will agree with me, the symposium has been a valuable platform for assessing and identifying gaps and strengthening our collective commitment in implementing Tanzania's National Action Plan on AMR 2023-2028. Throughout today's presentations and discussions, we've been reminded that AMR is a pertinent public health issue. Infections that you could treat with penicillins, now you can't even manage them. People are dying left, right, and center. And if you look at it in context, think of the deaths in MRI like all the 100+ buses that leave Ubungo terminal on one day, crashing, and everybody dies. That's how many people are dying, more than HIV, more than malaria, and we're not thinking about it contextually. So the symposium has also told us what are the drivers for AMR. They've looked at misuse of antimicrobials both in the human, the animal, the environment, the food sectors, the inappropriate prescribing, weak IPC, control measures, poor diagnostic facilities, and unregulated access to antimicrobials, and the disposal of antimicrobials into the environment, the results of food and the environment. All of these are drivers. But one thing that the panelists have discussed for us is the application and the critical role of a One Health approach in addressing AMR by promoting multidisciplinary collaboration and systems thinking. I really congratulate the Department of Microbiology because the panelists were very multidisciplinary, and that is One Health approach. The One Health approach will enable us, if we apply it, to effectively improve our AMR stewardship programs, improve IPC, enhance diagnostic, surveillance, monitoring of antimicrobial risk and resistance, but more importantly, to increase public awareness of AMR across all sectors. And it will also allow us to work together to apply innovative research methodologies like proteomics, genomics, metagenomics, but it also enforce regulatory systems across all sectors, human, animal, environment sectors, and how to support collaboration across sector, to source for research funding, and to share AMI data for the better of this country. Hence, implementation of the National Action Plan on AMR will depend on sustained multi-sectoral collaborations and prioritization of AMR in the budgets of all relevant sectors. AMR is a real problem that we need to work together across the sectors, but most importantly, we need to act now. And I would like to quote an African proverb that says, "One finger cannot kill lice. Kidole kimoja hakivunji chawa." So let's stop the silos and work together to fight AMR. And with those many remarks, Muhas would like to thank the guest of honors for his commitment and valuable time as the national AMR champion, the French Embassy for the continued support in the AMR fight, all speakers, panelists, presenters, organizers, and participants for their invaluable contribution and to the success of the symposium. I now, on behalf of the Office of the Deputy Vice Chancellor Research, declare the 17th University-wide Symposium on AMR officially closed, and thank you all for your participation. I wish you all a pleasant evening and a safe journey home. Asanteni.